we're going to start. I want to welcome everybody here. I'm Amy Horowitz, and I'm standing in for Liz Matthews. Laura and Liz needs two people to take over what she did so gallantly and competently in the past, but we need the two of us. So we want to welcome you to the symposium, where you'll have the opportunity to share the work that you've done all year with your mentors and with each other, and to share it with other students. And so I'm very happy to welcome everybody here. I just want to give you an overview, and of course, is that coming up there? No, of the program. We're going to try to keep to our schedule. And actually, I'll probably be a little less time in the intros, but we're going to start the presentations at about 5:40. Everybody knows that they have between 5 and 7 minutes per presenter. Some presentations have one presenter, some have multiple presenters, so it's 5 to 7 minutes per presenter. Then we'll have some time at the end for questions and answers and discussion, and then just some closing remarks, and I think Laura will take care of that. So again, just for an overview of what we will be hearing today from our research assistants in the program. The first presentation will be from students who work with Marciana, and I'm going to always apologize in advance for everybody's last name. No Marciana forever and still can't pronounce. Popsicle, whatever, and from quantitative to qualitative barriers and practices when working with asylum seekers and individuals with lived experience of forced migration. And the presenters will be Allison Adler, Sandy Castillo, and Chloe Saren. I apologize in advance. I'll let you introduce yourself when you come out. And then the next presentation will be those who are working with Elizabeth, with Liz Matthews, on roles and responsibilities of peer workers in behavioral health, a scoping review and content analysis. Next, I'm sorry, that's Danielle Gallus and Faith Scheifelbein. And next we're going to have this Laura John Mora, who was working with Abby Ross on the family-based crisis intervention adaptation for inpatients in psychiatric settings, followed by those students working with Rebel Rahman, and that's Rupal Patel, Cassidy Rosenblatt, and they'll be discussing applications of community-based participatory research. And last but definitely not least is a presentation by Casey Dean, who's worked with Samina Elzar on labor pains, a transgender marcus exploration of the impact of informal and formal work environments on access to medical care for cisgender women and Hydra living with HIV in Hyderabad, India. So it's very exciting to me to see the range of topics that people have worked on. And so I'm very happy to turn this over first to the presenters in the first presentation who are looking at asylum seekers and migration. Okay, so everybody's going to be sharing their own screen and we will continue.
Can everyone see my screen?
Mm-hmm.
Okay.
I can. Very good.
Okay. So I'll begin. Good evening, everyone. My name is Chloe Sarantopoulos. And
thank you.
Yes, of course. And tonight I'll be presenting the first part of our project titled From Quantitative to Qualitative Best Practices, Barriers and Best Practices when Working with Asylum Seekers and Individuals with Lived Experiences of Forced Migration. Okay. So for the first part of our presentation, I'll introduce a little bit about Her Migrant Hub, the social initiative this project coincides with, made up of educators, including our faculty mentor, Marciana, co-director Dana Alonso, and Tanzilia Oren, project coordinator and PhD candidate, along with our core group of women activists and Fordham social work graduate students. I'll present our research findings from the survey and implications and future directions. Sandy will follow with service provider survey findings and conclude with best practices. And Allison will present on topics of xenophobia and discrimination, including qualitative data and personal narratives. So, as stated, this project is just part of our work that we're doing at Her Migrant Hub, whose mission is to elevate the voices of women with lived experiences of forced migration and build a community through collaboration, participation, education, and advocacy that works to eliminate barriers and address social issues that prevent women migrants in New York City and beyond from accessing quality health and mental health care. So I've included our vision and values in this slide for everyone to review, and our link on the bottom here in bold. I highly suggest everyone check that out at some point. So moving on to background and significance. So our research is trying to answer the question, what are the main challenges or barriers to accessing health and mental health care for women with lived experiences of forced migration, including asylum seekers, refugees, and survivors of violence living in New York City? So I think it's very clear the significance of this research question can be supported by the current events happening across the world and remains relevant to our current mission at Her Migrant Hub. So as indicated by this graphic, according to the UNHCR, over 84 million people have been forcibly displaced worldwide. And current emergencies, including the war in Ukraine, humanitarian crisis in Afghanistan, continues to impact the increasing numbers of people fleeing their countries of origin in search of refuge. Some statistics here, over 4.6 million Ukrainian refugees are estimated to have fled the country since the end of February of just this year. And there are more than 700,000 Afghans newly displaced inside the country as of 2021, with 80% of them women and children. And another example includes the ongoing crisis in Venezuela, forcing individuals and families to escape great violence and deplorable living conditions, with over 950,000 asylum seekers and 6 million refugees and migrants worldwide from Venezuela. So going back to our research question, this is significant because those with lived experiences of forced migration, especially women, are likely in need of resources, support, and a range of services when they enter a new country as a refugee or asylum seeker. They'll often face challenges due to language barriers, discrimination, trauma, and PTSD, and much more. So this research question guided us while creating the survey to gain more information from this population and learn a little bit more about the challenges that they face in this country. And so our survey was created and distributed to women in New York City, and we used respondent-driven sampling, which is the preferred method for hidden and hard to reach populations, such as this, our target population. And it heavily relies on the social network theory. So using women activists from Her Migrant Hub group and others in formal social networks, we were able to provide unique survey links so that people can access the survey and we can track outreach efforts, and incentives were also offered. And others below here are listed that are frameworks and models that were used to guide us in the creation and distribution of the survey, and that are important to our work always. And moving on to findings, I won't spend too much time here due to time, but here is some demographics and background information. Something important to note is that out of 120 total survey respondents, 52 people completed 100% of the survey, so just a little more than half. And moving on to main findings, we've included on the slide specifically some of the greatest health challenges since coming to the US. Most frequent responses included fear of deportation, ongoing stress, and language barriers. And other responses indicated changes in emotional health due to migration experiences, as well as the COVID-19 pandemic, which we also asked questions about. And connecting back to our main research question, focusing on greatest barriers to accessing health and mental health care services, we can see here that the greatest barriers were too expensive, we can't find services, and that we can't find services in our native or familiar languages. And then here on the left side, we have other reasons why.
Great, 1 minute.
Okay. So other important findings, again, I won't go too much into this because of time, but most important healthcare services this is important in terms of how we will move forward and how to inform service providers, and then best venues to learn about services and rights of asylum seekers. So we'll continue to use these findings in our work in her Migrant Hub. And lastly, conclusions and future directions. These findings, I think, definitely provide us relevant information how to help us better address the barriers in accessing care for this population, and more importantly, how to bridge the gaps between service providers, social workers, and women activists, and those with lived experiences of forced migration in order to best provide care, share information, and gain knowledge about forced migration journeys and experiences. The importance of trauma-informed care, as well as the significance of language barriers as a barrier to accessing healthcare. And I will end on that and transition to Sandy, who will talk a little bit about our service provider survey.
Hello. So I'm gonna give you guys a brief overview of the service provider survey. So the survey was developed to collect information on health, reproductive health, and mental health challenges from the perspectives of service providers. The survey was created with Qualtrics and distributed to service providers who serve women with lived experience of forced migration and other immigrants. Data was then analyzed and will continue to be analyzed with SPSS. Next slide. So the service providers, so I'm just going to go through like the brief findings of it. So it's a small sample of service providers. We need to recruit more and get more participants to actually fill out the survey. And service providers, as the service providers that we have right now, they provide skills training services, forensic evaluation services, and immigration and legal services. It is important to note that no service providers offer transportation for beneficiaries, which is important because this could be a challenge for women with lived experience of forced migration and other immigrants to even receive these services. And according to service providers, the main challenges working with people with lived experience of forced migration are insufficient resources and current policies. Current policies include broken and unjust immigration system and limited refugees and asylum seekers coming in during the Trump administration. Next slide. Yep. Okay. So according to service providers, the main challenges for asylum seekers in seeking health and mental health care are lack of knowledge / information on existing services, and other can mean lack of cross-cultural understanding, stigma, and past persecution inflicted by psychiatric institutions and medical professionals in their home countries. And according to service providers, main challenges for refugees in seeking health and mental health care are lack of knowledge, information on existing services, cost-related concerns, no health insurance, language barriers, and multiple caregiving responsibilities. And lastly, according to service providers, main challenges for people with temporary protected status, TPS, in seeking health and mental health care are fear of deportation, lack of knowledge and cost-related concerns, language barriers, and a general lack of trust in healthcare services and providers. It is important to note that the service providers found commonalities within the main challenges for asylum seekers, refugees, and people with TPS, and that they all find that the main challenges is the lack of knowledge and information on existing services. So, and also service providers also reported that the main challenges for refugees and people with TPS are alike in that they find there are challenged with cost-related concerns and language barriers. So this is just important for future implications, just because just for like social workers and mental health providers and just service providers to know that there is a lack of like just some information on existing services, and there's a need to increase the awareness of services around the city and New York City and the boroughs, and there's also a need to increase the services for this particular population. And yeah, that's it. Next slide. Yep.
Okay, thanks, Sandy. So building off of our findings from both the service providers surveys and the surveys that we gave to women asylum seekers, I'm going to go over what we've learned from the qualitative data this year. And during this year, we continued with qualitative data analysis of narratives gathered in focus group meetings, through individual written narratives, and through digital stories, which is a new component of our project that we added this year. We used a grounded theory approach while looking at these narratives. We worked together as a team to identify themes that we see in the narratives instead of imposing them beforehand. And in all of the narratives this year, xenophobia and discrimination were a huge theme. And we see how legal status, gender, language, and national origin intersect in ways that impact the health and mental health of female asylum seekers. Next slide. So just to quickly give some context. So as the first quote points out, asylum seekers do have the same needs as refugees, but these needs are less likely to be met because of their legal status. Asylum seekers are caught in an in-between position, so they're de facto undocumented until their cases are processed, and they are not eligible for most public benefits. And that puts them in a very precarious position that's both discriminatory and it leads to discrimination. And this is a situation that can cause or contribute to poor mental health or exacerbate the trauma that asylum seekers have already experienced as forced migrants. And as these quotes reveal, xenophobia and discrimination is built into systems, so it is latent in the way in which asylum seekers are left outside of the social service system and outside of networks of care because of their legal status. Next slide. So women in our group shared experiences of xenophobia and discrimination that in all cases inhibited their access to services that are necessary for their well-being. And also it made them feel unwelcome and unsafe. And the excerpts on this slide demonstrate instances where the women experienced discrimination on the basis of their legal status and national origin. So in the first case, a woman was denied shelter because of her immigration status, which is illegal actually, and it forced this woman to put her life on hold and to risk the safety of herself and her family. And in the case of the second woman, she experienced xenophobia in the doctor's office, and such an experience could impact the care that she receives and her desire to return to the place where she's trying to receive care, and that also risks her well-being. And in the next slide, we see how the intersectionality of being an asylum seeker and a woman put this particular woman at risk for sexual harassment. So women are already at risk of sexual harassment on the basis of their gender. But when this intersects with legal status, a person like this woman's boss can use both grounds as reasons for harassment. And in this case, the woman also did not feel safe reporting the harassment because of her legal status. And that made the situation even more unfair and more uncompromising to her safety. Next slide. Okay. In addition to discrimination based on legal status and national origin, a lot of our participants face discrimination based on language or accent, which again put their safety at risk and inhibited their well-being, whether in public or in the workplace, as we see in the first and second quote. And I think it's interesting to look at the first quote and the last quote together, because one is an example, the first one is an example of very overt discrimination, while the last one is on its surface more benign, where this woman was speaking with a representative over the phone and he just noted her accent. But in both cases, language and accent, they're out in the open and in public space. And these women encounter someone who thinks it's open to consumption and to questioning and to silencing. And as the last quote points out, sometimes we need to acknowledge as practitioners that that's not always the case. Actually asking someone about their national origin, especially for forced migrants, can make them feel unsafe. And next slide. Oh, sorry. And that sort of discrimination on the basis of accent or language can actually lead practitioners to gloss over the particularities of an individual and their situation. And I think we see this in this quote. So in this narrative, we see how being female, being an asylum seeker, and speaking a different language intersect. This woman felt unheard by emergency personnel who didn't understand that she feared going to the hospital because she was an asylum seeker, so she's not eligible for healthcare beyond emergency Medicaid. And on top of this, she felt like she was not understood as a woman and that normal symptoms of her menstrual cycle were exaggerated. And she suggests that these could intersect with language and that someone who does not speak English could end up in the hospital with an unnecessarily large bill. So for our project, all these instances of xenophobia and discrimination led us to consider the ways in which we can amend our practices as social workers and the systems in which we work to take these experiences into account. So we asked, what can we do to help asylum-seeking women feel safe? And what can we do to bring them the service they need? And we can gather from the words of the women activists in our group, and specifically from their experiences of welcome, some important suggestions for how we can help them feel safe and provide them with services. And this also builds off of the responses that we see in the surveys that Sandy and Chloe just went over. So the first suggestion was to use welcoming language and attitudes. And the first quote is an excerpt from a really powerful story in which a woman spoke about her experience of seeing a sign that specifically said that this hospital didn't care about her legal status. They only cared about her health. And that made a really powerful impact on her and made her feel safe. Next slide. And the next suggestion is to sort of builds off of welcoming language and attitudes is to have information and services available in the languages that asylum seekers speak. Providing them with information in their language of origin empowers them and allows them to make informed decisions and also helps them feel supported. And lastly, the final suggestion is to create and encourage the creation of networks of support. In the experience of the woman in the first quote, connections between multiple organizations helped her to achieve all of her goals. And the second quote points to the importance of asylum seekers helping each other. So it's important, and this woman spoke about the importance of meeting a fellow asylum seeker and how they helped her and her wife sort of get started in the US. So it's important to connect forced migrants with each other in welcoming spaces. And that's also one of our goals through the Migrant Hub initiative.
Okay, so I'm going to quickly go over best practices, and this is based on literature reviews that Allison, Chloe, and I basically wrote throughout this year. My literature review focused on unaccompanied minors, since that was the population I worked with for my field placement. So it's the first one is, what are the best screening instruments and clinical practices to utilize with unaccompanied minors who experience traumatic events? So that's my overarching guiding questions. And for Chloe and Allison's, it is, what are the best practices with asylum seekers? Number of articles. I used 11 articles for best clinical practices with unaccompanied minors, and Allison and Chloe used 9 to 10 articles for best practices with asylum seekers. Just to reiterate, so I focus more on best clinical practice with mental health professionals to use while working with the unaccompanied minors who have trauma symptoms. And Chloe and Allison worked on best practices working with asylum seekers. All right, next slide. Okay, so for best practices for literature review on unaccompanied minors, so according to a study that I found, this study looked at 30 unaccompanied children from a southern western state that they were recruited from middle school and high school. And of these 30 students, over half of the youth scored in the clinical range for PTSD, 30% in the range of possible major depressive disorder, 30% have reported suicidal ideation in the last year. And of these youth, 100% who are in the clinical range for PTSD also scored in the range for possible depression. So this is a significant study because it does show that many of these unaccompanied minors that do come from other places in the country, like other places in the world, the Northern Triangle specifically, have a major PTSD and major depressive disorders. And so I looked at the screening tools such as the Child PTS Symptom Scale, and the Child PTS Symptom Scale is in the study that I found, the Child PTSD scale was used with unaccompanied minors, with a population with a sample of unaccompanied minors, and it yielded high reliability. However, that specific study had a particular limitation that the unaccompanied minors who filled out the scale were only concentrated in one location in one state, so it wasn't general to all the unaccompanied minors in the United States. And the Harvard Trauma Questionnaire and the Hopkins Symptom Checklist for adolescents, they all yielded high reliability in the study that they were used in. However, the Harvard Trauma Questionnaire in the study that it was used in, it was used with unaccompanied refugee adults. Refugee adults, it's an unaccompanied, but refugee adults. And so it wasn't towards adolescents or youth. And then the Hopkins Symptom Checklist for adolescents was used by unaccompanied refugee adolescents. And so both of these studies had limitations in that the studies were not used with unaccompanied minors from the Northern Triangle. So, and also the population wasn't from the Northern Triangle either. So there's not a lot of scales and measurement tools to detect trauma symptoms or depressive symptoms for unaccompanied minors. And also processes, there's culturally modified trauma-focused cognitive behavioral therapy, which is kind of a new process. It was made specifically for Latino children. However, it doesn't have a lot of evidence-based. It's not really evidence-based, so it needs more research to be done. TFCBT is widely used with unaccompanied minors, and it is evidence-based. Future directions is to create culturally sensitive instruments to assess trauma and possibly depression for these unaccompanied minors. Like I said, there's not too many of them, and devise new practices suited for this population, for this particular population. Okay, and slide. Okay, so best practices, literature review, asylum seekers. So trends in literature on best practices for asylum. Okay, in general, there are no national international standards. So they found that it needs to incorporate human rights principles and values. It needs to take best practices need to take a holistic approach and work at multiple levels. And it needs to emphasize social relations and social inclusion. Future directions need more research to measure best practices and make them evidence-based. And we need to incorporate more community input. Like how can we promote human rights if the communities affected are not involved? We need to incorporate communities within our research. Okay.
Yes, thank you so much. I was gonna.
Thank you. I'm going to start sharing my screen. All right. So this is our presentation on roles and responsibilities of peer workers in behavioral health. So we did a scoping review and a content analysis, and I'm gonna hand it over to Faith to start us off. Oops.
All right. So the Substance Abuse and Mental Health Services Association defines peers as people who have been successful in the recovery process and who can help others experiencing similar situations. So in our very extensive literature review, we kind of found like peers are really filling in these roles that social workers, mental health practitioners, even physicians aren't really filling to kind of enhance the treatment process for these individuals. So we found that they have really unique value in helping clients, patients with trusting practitioners. And they also provide this sense of hope that things can actually get better because they're actively working with someone who's already been through the treatment process, the recovery process, whatever it is. So they see this like beacon of hope and success that they can kind of follow in their footsteps. And so the purpose of our study, beyond just looking further into the peer role, was this federal mental health strategy that identified creating a national peer certification program was a priority in order to accelerate universal adoption, recognition, and integration of the peer mental health workforce across the healthcare system. And this sort of sets up the whole purpose of our study, which was that roles of peers have been ill-defined, where people don't really know what they do. We know that they fill in gaps and are a really good support system for clients and patients, but nobody really knows how to utilize them appropriately. So that was what we were trying to do with the purpose of this, so that we can help kind of integrate them into those best practices. Next slide. So these were our main research questions. They kind of developed day by day still. But we started by just looking at what are the roles that these peers are playing, both in mental health and substance use settings. And we found that those are very different, which we'll get into later. And then we also looked at what the differences are in those responsibilities of the peers across those two contexts. And I'll pass it back to Danielle.
All right, so for our methods, as mentioned before, we use a scoping review, and you might be thinking, why a scoping review over a systematic review? Well, because as mentioned before, peers are, their definition is very ambiguous. So a scoping review is more appropriate to utilize for this, because we want, our goal was to see, you know, the characteristics of peers and concepts surrounding peer workers in behavioral health, rather than seeking evidence for their effectiveness. So that is why we chose scoping over systematic review. And then we went into a content analysis so we can further categorize and describe the roles and responsibilities that peers may take on in different contexts and of behavioral health. And for, you know, our inclusion criteria for our scoping review, we excluded those that were outside the US. So let's say there were a lot that were from Australia, we excluded those. And it had to be involving mental health or substance use. So if it involved strictly physical health, then that was excluded. For the intervention, we included those that were directly supported by peer workers. So that could be peer workers facilitating individual work, or facilitating group work, or co-facilitating groups as well. And then for outcome, we included reports about that included the describing peer workers' roles and responsibilities and key tasks and job functions. So we wanted to make sure that what we included gave some context to what the peers' role was, how they were working with individuals or in groups. So we excluded those that did not really make mention of that. And then for study design, we included qualitative or quantitative. So it had to be original data and findings. So we excluded those that weren't original findings. And then just to take you through our scoping review process, we first identified 3,139 records from our database search. Then we removed the duplicates. So therefore, after the duplicates were removed, we had 1,890 records left. And then we moved on to screening. So we would look at the abstracts just to make sure it fit in with our criteria. So then after that, we excluded 1,795 records. And then we went into further a full text review. And then we assessed 95 records. And then after exclusion, we we excluded 51 records from the 95. Sorry for all the numbers. I know it can get a little confusing to follow, but the flow chart does a nice job to show you our process. But so at the end of the day, we included 43 records, and just to break it up into categories, mental health, we had 28 records, and then we had 12 records for substance use. And I apologize, I can't see the bottom of my slide for mental health and substance use records, but what was the number, Faith? Sorry, I can't, it's blocking.
There's 3.
Okay, thank you. My apologies, Zoom. So that was our scoping review process. So these show the results that we got from our content analysis. So this is where we looked at how peers were described, and then we categorized them. So in order to further break up their roles, we noticed there was an informal and formal aspect to these roles. So informal and unstructured, we realized that's more so the process of relationship building with clients, and there's no explicit agenda. It's kind of just meeting the immediate needs and concerns of clients, meeting them where they're at. So it's kind of, if you think of it as when a therapist starts out, building that rapport, that's kind of how you can see that it's more informal and unstructured. So I'm not going to go into every single one of these responsibilities and roles because for time's sake, but for some that might not be clear in terms of peers, I'm going to start with describing role modeling or mentorship. So this in particular is when there's talk of the shared experience between the peer and the client. So this is really important for that trust building that is essential in this work. And so that could be used through emotional support, hope, motivation, advice. And also, I think what is very important is normalizing the experience so it's less to destigmatize. So let's say we're talking about substance use disorder. So if a peer is mentoring some client who is experiencing substance use disorder, they can provide them with their experience and kind of see what it looks like to be on the other side. So that not only normalizes the experience, but also gives them hope that they too can recover. And then check-ins is another part of the informal role. So moving on to the formal and structured. So formal and structured, let me explain that first. So the formal and structured roles and responsibilities are those that are particular evidence-based practices. So it's with clear expectations, there's a clear agenda, as a therapist would make a clear agenda and set expectations, and in sessions, that's basically what peers would do in this more formal and structured role. But there's different roles within the formal and structured. So just explain what instrumental case management is. So peers would help clients gain access to needed social programs, including, let's say, housing or education, and then community linkage. So it helps clients identify and connect with social supports. So kind of getting them connected with their community and feeling included. So that could be AA, church, and any support groups in the community. So that's kind of the difference between the case management and community linkage aspect, because it kind of sound very similar. And then I know structured intervention sounds very straightforward, but you might think a peer can do a structured intervention, and actually they are able to facilitate individual or group-based interventions. So they are trained in a particular evidence-based practice or approach, and then the peer had a particular responsibility in leading or supporting delivery of these programs, and they documented progress. So similar to a clinician, they would provide clients with either the individual or group-based intervention. So that could include, from our scoping review and content analysis, we found this could be in the form of psychoeducational, problem solving, vocational or motivational interviewing. We even saw DBT and CBT being utilized by peers. And just to name off the rest of the formal and structured roles, we got care coordination, planning and goal setting, community outreach, screening and intake, and then psychoeducation. And I'm gonna bring it back to Faith.
Awesome. So we are still actively working on our results, but these are kind of preliminary results that we've started diving into. So this graph sort of demonstrates the distribution of the peer roles by their categories that we kind of identified that Danielle just talked about. So in the blue is mental health and yellow is our substance use settings. And the green bar represents kind of the frequency of the role that's used with both behavioral health settings combined. So for example, 50% of our studies indicated that role modeling or mentorship were utilized, whereas maybe only 11% of the studies that we looked at included community outreach as something that the peers were utilizing as a role. So kind of looking at these trends just in general, it's pretty evident that the mental health setting had peers that were more often offering things like mentorship and the structured interventions, whereas substance use had some of these more informal or less structured, whatever you want to call it, approaches. So they used things more like community outreach and care coordination. So we have started to see that these more structured approaches might not be as favorable in the substance use realm, where they're kind of relying more on the community aspect of things, connecting them to community resources, whereas mental health and those clients significantly benefit from a more structured approach with those interventions and things like that, the screening, whatever you have. So we've also found that on average, the peers have a lot of roles. They're not just acting within just care coordination or just screening and assessment. They're doing multiple of these. So typically across the studies that we included, it's usually about two. But we've seen peers have up to 6 roles in these across these categories. And more than half of the studies that we looked at, the peers were included in both an informal and a formal role. Next slide. So just kind of a summary of what we've started to look at is peers are doing a lot and they're really filling in a lot of gaps, which is what we've been seeing across these studies and that we've been talking about. And they're very much used in both the informal and the formal settings. So it's still very difficult, obviously, to pinpoint exactly what a peer does because they have such a broad range of things that they're addressing. But there are those patterns that are starting to emerge that I just talked about. So the goal that we talked about earlier with our aims was to create kind of this standardized approach to creating a peer certification program. But we're finding that we'll definitely need to differentiate between what is kind of an essential aspect of what the peer does compared to what they need to be able to do in a mental health setting versus a substance use setting or whatever other settings you want to look at in the future. And we have also started to consider the fact that these role definitions have their benefits, like helping practitioners, mental health practitioners, social workers, whoever else is working with the peers understand how to use them better. But we also want to avoid creating such a structured role that they become kind of displaced from the client, which is what their benefit was initially. Thank you. So really our next step is just to understand where the effectiveness is exactly within informal versus formal programs that peers are used in, and then eventually work on those training and certification programs as well for peers. Yeah.
Great. Thank you so much. It's great.
So Amy, just to confirm, I'm up next, correct? Yep. Okay, great. So I'll share my screen. Thank you. Okay, so I've been working with Dr. Abby Ross on a project where we're adapting the family-based crisis intervention for an inpatient psychiatric settings. And so just to give a little bit of background and significance related to this project, obviously suicide is a huge issue. It is actually the second leading cause of death among adolescents ages 15 to 19. And the other issue is that the care that's being given to people who are dealing with suicidal ideation and attempt is not sufficient, and it doesn't encompass the family system adequately. Unfortunately, as many as 27% of children and adolescents ages 10 to 18 years old who do present to the hospital due to an attempt will attempt again. So the family-based crisis intervention integrates cognitive behavioral skill building, psychoeducation, therapeutic readiness, and safety planning, and uses a non-judgmental collaboration to provide psychiatric intervention for both the youth and the family. So this is meant to hopefully allow more teens to be able to safely return to their homes with their families, and also address some of the underlying issues that can, put children at an increased risk for suicidal ideation or attempts, given the lack of family support or the issues that remain unaddressed in the family system. So we are conducting the initial phase of this project currently. So we are doing we actually completed in-depth interviews with the leadership team, service providers, patients and their family members, or we're actually in the process of completing the patients and family members interviews. But I did a series of 15 interviews with service providers at an inpatient unit that we're collaborating with. And this phase was meant to explore current practices on the unit and, how those are serving families, or if there are any gaps, anything that we need to take into account in terms of how we're going to be able to implement this, this intervention on the unit. And we just want to get a sense of what are the needs of the, youth suicide survivors and their families. Also, what are some of the attitudes of staff on the unit towards work with family members? And we also obviously ultimately want to adapt this FBCI and FBCI related protocols for use in inpatient psychiatric settings. For phase 2, we're going to conduct a pilot RCT comparing FBCI IIP to treatment as usual. And we're looking at, for outcomes of interest, we're looking at feasibility, acceptability, appropriateness, and preliminary efficacy. As far as the patient and family outcomes, we're interested in suicidal behavior, obviously, family communication, family empowerment, and satisfaction with care. And then for systems level outcomes, we're looking at emergency department visits, crisis evaluations, and inpatient psychiatric readmission during the 6-month period following discharge. And then as far as the research methods, we are coding and analyzing qualitative data from the interviews. So all of the interviews that were conducted with service providers were transcribed verbatim, and then that data is being coded and analyzed using Atlas coding software. We meet regularly as a team to make sure that we're establishing inter-rater reliability and discuss themes that are emerging from the first round of interviews, which we completed. And that is a process that we're going to continue for the family and patient interviews as well. Those family and patient interviews will be coded the same way, but we will also be administering measures at 6 different time points, pre-test, post-test, 1 day, 3 day, 1 day, and 1 month time points. We expect that at post-test, FBCI-IP patients will report significantly higher levels of perceived family support and improved family communication compared to treatment as usual, and maintain gains at 6-month follow-up. At post-test, we're expecting that family members will report significantly higher levels of family empowerment, adaptive communication, and satisfaction with care compared to treatment as usual. And we're also expecting that the time between discharge and linkage to care will be shorter for patients who have participated in FBCI-IP versus treatment as usual. And obviously, very importantly, rates of suicidal behavior, inclusive of attempts, repeat emergency department visits, and psychiatric readmissions over a 6-month follow-up period, we're hoping will be significantly lower for patients who have received this intervention compared to treatment as usual. So as we were going through the coding and discussing the interviews with providers, we started obviously noticing some themes. We're in the process of still finishing up the parent and child interviews. And once those are complete, we'll be able to see how those compare to what providers shared. Thus far, some of the most important themes that have emerged are the possible, barriers and facilitators to care involved when you look at the whole family union. So family involvement can be a facilitator or a barrier to care. That's clear, and that's come up in a lot of the interviews. Also, there are cultural factors that can interfere with treatment sometimes, such as a particular culture's understanding of mental health and the challenges associated with that. There is also, of course, the impact of the COVID-19 pandemic. So that has in some ways facilitated access to care for some families because they can, remote in to be able to participate in family meetings and sort of keep track of their children's care. But, for other parents, it's been difficult because there's less access to the unit in person for the extended family unit. So a lot of parents, who are stuck at work or can't, make it in are having a hard time with that. And then also, obviously, the best practices and sort of the process that's in place on the unit currently come up a lot. So sort of questions of whether the providers feel that the current process is working for them, and that involves obviously challenges with interprofessional communication, a lot of comments on the treatment setting and the workplace environment came up. Most of them were positive, but there are certain challenges. Staffing is one of them, and that's to be expected. Usually, there are staffing issues that can get in the way of providing, the best care possible.
1 minute.
I'm trying to rush. I was so aware of it that I feel like I rushed too much.
I'm sorry. I hate to do that.
So that was really my presentation, because I know that there's a short amount of time for each presenter. So I don't actually have more than that. That was it for me.
I hate being the timekeeper. I really do. And I apologize to all of you. I'm just, conscious of the people that go after you.
Okay, good evening, everyone. Hi, my name is Cassidy Rosenblatt, and I will be presenting with Rupal Patel, and we are both research assistants for Dr. Rabel Rahman. So we collaborated on multiple studies on applications of community-based participatory research, 3 of which will be presented today. And this mode of research was used because of the equal partnership it produces between community stakeholders and the researchers. It's also known as CBPR. It not only promotes relationships between community members and the researchers, but it also creates a place for the population being researched to share their knowledge to improve situations. So ultimately, it was utilized for these studies because it's proven to be effective in working with marginalized populations. And we also want to mention that we worked on another study about COVID-19 stigma and depression across race, ethnicity, and residence, but due to limited time, we will not be presenting on that today. So before we start, we would like to mention other principal investigators that we had the privilege of working with on our studies. So we just would like to thank Dr. Tina Mashi, Dr. Abigail Ross, Dr. Samina Azar, and Dr. Laura Wernick, who were all instrumental in these studies. These were funded to GSS, and both Rupal and I, our roles were to conduct literature reviews and to write out the background and discussion sections of the articles. So community health workers, or they're also called CHWs, they're frontline public health workers who are trusted members of the community. They share the same lived experiences as their clients and work within homes, within community-based organizations, health departments, and in hospitals. In 2020, the US employed over 58,000 CHWs within New York State, employing the highest number at over 7,000.
I just want to make sure everyone can see the right screen, right?
We see personal challenges and strengths by community health workers and maternal and infant services.
Okay, perfect. So the first study to be presented is personal challenges and strengths by community health workers, which I will call CHWs, and maternal and infant services. The purpose of the study was to understand CHW workforce issues from the perspectives of leadership and upper management within New York State. These supervisors were selected from organizations part of the Association of Perinatal Networks of New York. I was tasked with conducting the literature review for the background and discussion sections of the manuscript. So while there was concrete data collection and analysis procedure, I'll only be focusing on some of the most pertinent data I found in the literature. As valued members of the community, clients often turn to CHWs for health advice despite their limited training. This could be due to their use of jargon-free communication, local idioms, and storytelling to more effectively impart their medical skills. CHWs who perform home visits also have a unique view into their clients' vulnerabilities and potential risk-taking behaviors because of the nature of their work, which gives them access to their clients when they are the least guarded. Unfortunately, despite evidence showing the efficacy of CHWs in improving the health outcomes of marginalized populations, the lack of formalized and uniform training, inadequate supervision, and low pay present many challenges, including high turnover rates, difficulty determining when to refer out a service, and experiencing burnout from repeated exposure to client trauma that often mirrors a CHW's own due to their close community ties. The Affordable Care Act has renewed interest in funding within the US to focus on improving outcomes and reducing costs through innovations in health service delivery, such as the integration of CHWs in primary care. So the ACA right now includes funding for hiring them for things like promoting healthy behaviors, conducting outreach to increase health insurance enrollment, and providing home visitation services for maternal health and prenatal care. Despite this growing national interest, there's no national program for community health workers in the United States. So because of this, there's a lot of substantial regional and state-based variability in terms of population served, the illness that's focused on, training, and supervision. So right now, New York State only uses online training modules, which are not mandatory. These modules include things like CDC and HIPAA training and liability issues in the field. But other states have used an array of training modalities like role play, video critiques, mock phone calls, And these trainings, unlike the online modules that we use, are usually sensitive to a community health worker's education levels. Currently, 20 states have developed a certification standard for community health workers. New York has not. So in an attempt to establish a standardized set of core competencies for community health workers, Cover et al. In 2019 developed a community health workforce framework that specifies 3 categories of CHWs based on their training, work setting, and scope of practice. So as one goes up in category, their training and scope of work gets more and more specific, and their place of work gets more tied to healthcare institutions instead of grassroots community outreach. Implementing the above best practices, training and strengths-based approaches to counseling, intensive supportive supervision, and client empowerment techniques like the 3-step check-in could substantially improve community health worker performance without compromising the quality and timeliness of care. The second study that I participated in was examining service integration by community-based providers in New York State offering maternal and infant services. So we want to start out by first explaining what integrated services are. According to WHO, integration of services refers to the combination of multiple modalities of preventative and curative care, wellness and client. It's been shown to improve health outcomes, reduce duplication of services, and maintain cost effectiveness. It responds to a wide range of needs presented by any one client. For the purpose of our study, we define service integration as the screening, delivery, and referral making of 2 or more services over the course of 6 months. Services of interest include mental health, intimate partner violence, sexual health, and substance abuse services. The purpose of this study was to uncover the relationship between organizational level characteristics, such as job satisfaction and training helpfulness, individual characteristics such as self-efficacy, and integration and integrated services amongst community-based providers who are either home visitors or community health workers in New York State. So we recruited about 159 community healthcare workers and home visitors. So we were provided a list of emails, and they were sent, if they fit the inclusion criteria, an online survey, which was done on Qualtrics. Some of the measurements used in the survey were the job satisfaction survey, demographics like age, race, ethnicity, and income, and a self-efficacy measure that was previously used with community health workers in Brazil. And then for data analysis, there was a logistic regression used to examine whether organizational and individual level variables predicted the provision of integrated services. So in terms of findings, most community-based providers integrated for all 4 of the services we were looking at, with the most common being substance use and mental health services, likely due to providers who are proficient with integrated services finding the trainings that they get below their skill level. The helpfulness of the provided trainings was actually negatively associated with the provision of integrated services, and training that targets perceived self-efficacy furthers a community health care workers' capacity to perform tasks, which is associated with the provision of integrated services. We hope this study can lead human service organization leadership, workforce policy advocates, and legislators to strategize innovative training and supervisory tools using specific scope of work conditions to promote integrated service delivery.
So the next study we're going to discuss is burnout, compassion fatigue, compassion satisfaction experienced by community health workers offering maternal and infant services in New York State. So we're going to define what burnout, compassion fatigue, and compassion satisfaction are. So burnout is defined as a psychological response to long-term exposure to stress, mentally disengaging a provider from their work in response to the chronic levels of job stress. Then compassion fatigue is also known as the costs of caring, which is characterized by fatigue that can arise from witnessing or listening to the suffering of traumatic experience of clients. And compassion satisfaction differs from compassion fatigue since it is the positive experiences that CHWs feel when providing care, and the degree to which one feels successful at being able to work effectively. So our purpose for the study was to examine burnout, compassion fatigue, compassion satisfaction among CHWs offering maternal services in New York State. And the significance is that these CHWs have very strong ties to the community, and they provide a variety of in-home based services. The social, mental, and environmental observations that they're exposed to can put them at a very high risk for burnout and compassion fatigue. So we found that throughout their experiences, they get low pay, training, limited supervision, and work benefits. So all of these issues can contribute to burnout, compassion fatigue. So for our methods, we use an online survey platform called Qualtrics XM. It was utilized in the study to reach participants across New York State. So as shown above, 80% of participants identified as non-Hispanic, 66.7% as white, 97.33% as female, and the average age was 40.13 years old. And each of these measurements listed below were picked specifically to measure quality of life, anxiety, job satisfaction, adverse childhood experience, and role certainty. So these are our findings, and our first one is that high levels of anxiety put CHWs at a higher risk for burnout and compassion fatigue. So for example, high caseloads, toxic work environments, and long-term trauma exposure can contribute to high level of anxiety. And our second finding is that increased job satisfaction results in low burnout and compassion fatigue. So when they feel supported by their supervisor and their colleagues, they can effectively work out in the community and experience job satisfaction, which increases effectiveness with clients and community. So detering workplace isolation and fostering a belongingness in their environment is key to preventing burnout and compassion fatigue. Our third finding is that high levels of job satisfaction promotes compassion satisfaction. So any CHWs that worked more than 35 hours per week were less likely to have high compassion satisfaction because of the constant exposure to community suffering and trauma. And our last finding is that education on self-care and awareness on burnout and compassion fatigue among CHWs is needed. So there's still so much to learn and change about how they interact in an emotionally healthy and in agency supported way with community suffering in order to prevent burnout and compassion fatigue. So we had some study limitations, which included lack of research, limited agency consideration for the mental and emotional well-being of CHWs, and needed consideration on the first and secondhand trauma in the agencies that they worked in. So the research is needed on the overall well-being of CHWs to ensure best care from agencies, as well as the communities that they seek to serve. So although this study was effective, it did not measure the severity that the burnout and compassion fatigue are experienced. So we also found that additionally, this study was majority was female working within maternal health. So a diverse and general practice research study should be considered in the future to accurately depict the mental and emotional health concerns of all CHWs. So that is all we have, and thank you all for your time.
Thank you so much. we're still within time, and I do believe we have the last presentation coming up.
Okay. Hi, everyone. I'm Casey. I use she, her pronouns, and I've been a research assistant with Professor Azar over the past 2 years working on my presentation titled, let me get the PowerPoint up. Okay. Titled, can everyone see this?
Yep.
Great. So it's quite a long title. It's titled Labor Pains, a Transgender Marxist Exploration of the Impact of Informal and Formal Work Environments on Access to Medical Treatment for Cisgender Women in Hijra living with HIV in Hyderabad, India. So I'll do a quick introduction, literature review, theoretical framework, methods and ethics, and then go into the results and discussions of the study. So with the quick introduction, India represents about 17.8% of the global population and about 6.4% of the global population of people living with HIV. It has a Gini coefficient ranking of 35.7, which indicates significant income inequality, and roughly 62.5% of India's HIV positive population is currently receiving treatment. So looking at the Hijra community in India, Hijra is a term used to describe a portion of the third gender community in South Asia. It specifically refers to a person assigned male at birth who now identify as female and are believed to have spiritual powers. India also has a caste structure system that is a hierarchical birth system used to reinforce social expectations associated with class. Most of the respondents in our study belonged to the lowest caste system, Dalits. Each of these contribute to intersectional stigma experienced by respondents in this study. So going into the literature review, HIV research traditionally focuses on cisgender men and cisgender women, leaving out their gender and gender non-binary folks. HIV research in India also focuses on access to treatment rather than access to work as a barrier to care. So this research project fills in both of those gaps. The theoretical frameworks we chose for this study were Marxism and transgender Marxism. We focused on a couple of different components within each framework: the stagnant population, which includes a portion of laborers involved in irregular employment, the conditions of which fall below the average conditions of the working class, and the working day as a concept that Marx defined as something where the capitalist controls because they purchase labor power and expect the laborer's time to produce a commodity at the end. Labor movements have traditionally put restrictions on the length of the working day, moving it from 13 hours to 9 hours, but unfortunately these movements have still eclipsed marginalized workers. Another theme that was important in Marxism is hoarding of capital. And he explains that hoarding of capital and saving money from circulating back into the economy is intentional as it reinforces the social structure and expectations with class. We decided not to actually go with feminist Marxism because feminist Marxism tends to reinforce the binary structure of gender that we want to move beyond to create a more inclusive framework. So then transgender Marxism expands beyond the gendered experience of class and work, noting the importance of labor to organize, building informal networks for survival, and dismantling gendered expectations associated with certain types of work. So going into methods, we did 32 in-depth interviews. We had several conditions for eligibility regarding residence, age, HIV status, language proficiency, and gender identity. We also used a combination of purposive and convenience sampling, and we were sure to include incentives for reimbursement for their time and consent and confidentiality in recruiting. So going into the results, we found three major themes that were highlighted in many of the quotes that we highlighted. And they were burden of taking time off work, loss of pay, and interruption to caregiving responsibilities. So I'll give you a few seconds to read the quotes here. And then for interruption to primary care work responsibilities, we have this quote. So then going into the discussion, burden of taking time off work really spoke to the exchange of labor power failing marginalized workers and restrictions in quantity of doses of HIV meds distributed to providers also reinforce stigma of low income or marginalized workers, or what Marx would call stagnant population workers, and that they didn't have, or because they didn't have work, they had the time to go back to the hospital to get meds every few days, which wasn't the case. loss of pay. This theme reinforces Marxist critique of capitalist systems because the pay workers receive for their time to build a commodity is received at the end of the exchange. And again, because sustained work is undependable for marginalized workers to count on, this practice forces these workers to go into debt in order to rehabilitate their need for another working day. And then interruption to primary care work responsibilities. We found that the heteronormative family units have prescribed gender roles, and this is pervasive and systemic in society based on the way that the economy is structured off of a family unit. And any kind of disruption from those gender roles lead to isolation and exploitation. And that is the end.
Yay. Wow, great presentations, everybody. Really, really fantastic. Huge round of applause. Now is the time for Q&A. I really encourage you all, especially the students, if you have questions for one another, I'd love to encourage you all to take the first round of questions. Does anybody want to jump in, take a risk? There are no bad questions. All questions are important. All right, I will now open it up to everybody else, but any students that raise their hand will get put into priority. Any of the faculty or anyone else? Yeah.
Well,
Amy.
No, I was just going to ask, well, if you don't want to ask questions, perhaps you want to comment about your experience in this program and what this has meant and what you want to take with you.
Yeah, Cassidy.
Yeah, so this was a very, I really enjoyed this experience because I've been wanting to do research for a while and wanting to get hands-on experience. And I was very excited and happy that I got the opportunity to do that. And it was great to collaborate with Dr. Rahman. I had Dr. Rahman as my professor, but it was great to work with her again and RuPaul as well. And I'm very passionate about mental health, and I want to be someone that can expand mental health research. So I was very happy to be a part of it.
Chloe.
Yes, I thought everyone did a great job. It was so nice to learn from everyone as well. I had a great experience this year in the program. And I too want to continue using research in the social work field. So this was a great learning opportunity. And also just another comment, something I found interesting was that all of our presentations kind of related to health, but in different ways. So I thought that that was a kind of a nice thing tying all of ours together.
Oh, anybody else? Yeah, go ahead, Laura.
So I was I think this was incredible. I was super impressed with everybody's work and what they're doing. And this is actually my second year in the program. So my experience has been kind of transformative because when I came into the program, I was frankly intimidated. You know, when it comes to research, that was an area that felt like hard to break into. And now I've gotten to the point where I feel like I'm really in it and want to continue to do it and feel confident that it's going to be a part of who I am as a social worker moving forward. And I have to really thank Dr. Ross, because she has given me many different opportunities just in the span of these 2 years. Last year, we were doing something completely different. Then having a chance to do this year has been amazing. And I just feel like it's a very supportive sort of model, having the faculty, you know, mentor, and having somebody that you can, I mean, end up speaking in you know, a broader sense too, about your research interests and your future plans. So obviously the content and the knowledge that you get from that person is one thing, but also just that supportive sort of mentorship kind of relationship is something that I think is really valuable.
Thanks, Laura. Anybody else want to speak? Yeah, Casey, go ahead.
Yeah, I just want to echo similar comments of how great and wonderful it was to be in this program, to be able to, you know, have that mentorship experience and have somebody who will encourage you to explore all your random interests that you have in a research setting. Like if you asked me a year ago if I would be reading Marx, I wouldn't say, I couldn't imagine it, but here I was, so yeah.
I'm so glad to hear you're reading Marx. Shall we all read Marx? Anybody else? Yeah, go ahead, RuPaul.
So I was, you know, between undergrad and grad school, I took a very long break, and this was getting back into education was very daunting for me. And I felt like this really gave me a rapid introduction into faculty that I normally would not have met my first year or even my first semester. You know, and I got to really form a community with the rest of the cohorts. Like Cassidy is graduating this year, and now I have a connection that's going to start practicing soon while I'm still in school. So I think just the, you know, getting the community sense of this when you're first entering Fordham was a really great opportunity for me.
That's great.
And yeah, and I just want to remind people, those of you who are in your first year, it is possible for you to reapply for next year. So look out for those notices.
I'm curious if anybody, go ahead, Amy.
Yeah, no, and you know, you can talk in your application about your work this year, and that would be great.
Yeah, absolutely. I hope you do consider applying again. And I'm curious whether or not there's been any interest sparked among you all in continuing on and possibly doing a PhD or going into the field and continuing research there. I see some head shaking.
Yeah.
Great. Well, I hope you all continue. I was personally really excited about all of the work that you all did. I learned so much, and it was also great to hear about the work of my colleagues, which we oftentimes don't get to hear enough about. But it's clear that they had an amazing team of students to work with this year, and I really do hope you all continue. If any of the faculty want to say a few words before we log off, I would encourage you to do that.
I just want to say I'm very impressed with everybody's work. I think we are so very lucky to have been able to work with you all as a group of students. I know for my project, you know, that Laura has been working with me on, She's been invaluable in terms of getting us through this first phase of qualitative interviews, which is going to inform the next intervention development phase. So I'm hoping, Laura, you're going to reapply and you're going to stick around because I love the continuity. And certainly, I think, well, I would imagine I can speak for all faculty. Anybody who is considering, more research, more doctoral stuff, of course, we're all happy to remain in contact with you and talk with you about your aspirations and how to strategize in that thing.
Thanks, Abby. Robel.
Yeah, I wanted to thank all the research assistants because, giving 100 hours per semester over on top of your classes and your internship is a lot. And I think most of the research assistants did, presented such amazing work. In terms of this program, Rapal was able to get a summer fellowship through one of my grants. So she will continue to be working on a research project with me. So that's been amazing as well, that we will continue to work in the summer as well. So, this also allows us to have, ongoing relationships or, partnerships with students as well. And, to say it like, I felt like I was able to push through so many of my manuscripts that were stalled because of COVID. And, because of all their hard work and them going ahead and doing all these literature reviews, I was able to, submit everything. So it seems like, I also was productive while the students, through their hard work, also hopefully got something out of it as well.
Yeah.
Also, just to echo, the presentations were amazing. Lovely to hear about everybody's work. I'm really going to miss working with Casey. We've had just oh, sorry, that's my husband. Lovely relationship over the past couple of years. And she first authored the manuscript that she just presented here, which is really exciting. And if I may speak for her, thinking about applying to social work PhD programs in the future. So I think this space is truly unique. I surely didn't have this opportunity as an MSW student. And I think I had written off research for a long while because of that. So hopefully there's a different experience for folks in the room as a result of this. And good luck to you, Casey. I'm really proud of the work you've done and for introducing you, not solely, but at least nudging you in the direction of Marxism.
Great. And Liz Matthews, who I have to say has been instrumental in making this whole MSW RA program happen. So hats off to you.
Oh, thank you. And I'm sorry I don't have my video on. I'm kind of squirreled away. But thank you to Laura and Amy for really keeping this going and organizing this and giving some great opportunities to everybody here throughout the course of the semester while I've been on fellowship. But wanted to just give a shout out to Faith and Danielle. I have had the pleasure of being able to work with Danielle for the past 2 years, which has been amazing, seeing her kind of dive into qualitative work and then really work through this systematic review along with Faith in kind of a long and iterative process. And it's very exciting to kind of see the results come out of it. And then an added bonus was getting to know Faith this year and just seeing her kind of eagerly dive into this and like really dive in headfirst into a lot of literature. And I'm sad that both of them are going to be leaving this year. But just generally, it is always really impressive and really exciting to see the culmination of what the RAs have been doing. All of you have been working so hard at this year, and it's so impressive to see all of you speak so concisely and eloquently about research topics that are really complex and research methods that are really rigorous, and the faculty in the room have spent a long time learning about. So I just really want to give you all props for kind of stepping up and doing this. And I hope that it was a good experience for you all. And I'm always just so happy to see it. So good luck to all of you. And thank you to Laura and Amy again for putting this together.
And on that note,
and thank you to Liz for making it happen.
yeah, thanks for all coming, and thank you so much for your presentations and for teaching us all so much.
Yeah.